Generally not. I will reflexively order genomic profiling on both tumor and blood samples when patients do have recurrent metastatic disease. However, that generally does not inform my first-line treatment recommendation because they are going to get immunotherapy regardless, whether it is standard of care or as part of a clinical trial. Yeah, so the Head and Neck Cancer Alliance does have patient education resources that can be helpful. So Head and Neck Cancer Alliance, American Cancer Society as well. Usually it's a smattering of different patient education resources from various sources, but I think the Head and Neck Cancer Alliance would probably be most meaningful. I'm going to remain hopeful that a therapeutic vaccine will be developed that is useful. You know, there's a lot of research looking at therapeutic vaccines, but to date, and we've participated in some of those trials, the efficacy just hasn't been there yet. But I'm hopeful. In terms of how we're going to select, I think at the beginning it's going to be basically agnostic. If it's HPV mediated, they're going to be offered. And then based on what we see will help us further refine. I think that's practically how it's going to go. I think it's prudent to monitor for up to a year, just given the data. Inevitably, most of these individuals are under our care for surveillance anyways, so we may be monitoring them beyond that. But I would say a minimum of 3 months, but ideally up to a year if you can. Yeah, I think it really just depends on the toxicity, where it's at, how severe, what I had to do to basically get it back to either resolve it or get it back to a much more manageable level. And then it's really important that you talk to your patients. Some patients, even if we don't think the toxicity was that severe or that concerning, they might. Conversely, I had a patient where I had her on Pembro plus cetuximab. She developed a small bowel obstruction, which we suspected was due to the EGFR. I had to stop her therapy because of that scenario. She ended up getting an ostomy, and she had a complete response, but after being off of therapy for quite some time, she recurred again. And she came back to me and said, I want to go back on the same therapy because it worked. And I explained to her, well, it may or may not work the same way. And you had a pretty significant toxicity of bowel obstruction requiring an ostomy. I spoke with the surgeon. The surgeon said, she's already got the ostomy. So from my perspective, if you want to re-challenge, you're welcome to. So we did. I will say I wasn't confident about that. And I felt, my anxiety level was much higher. She went back on that therapy and did not have any further bowel issues. And she had stable disease, I think, for a period of time. So I highlight that just to say, again, it really depends on a variety of factors. You have to talk to your patient and take into context what that toxicity is and your comfort level with re-challenging. But if you are going to re-challenge, please make sure that your patient is savvy and you're seeing them in case any acute issues arise abruptly.